Hello everybody, my name is Stephen Stonelake. I'm a registrar in colorectal surgery at Walsall Manor Hospital in the UK currently, and it's a great privilege to join you virtually at the conference to talk on the topic of ERAS, enhanced recovery after surgery, and it's my hope that this is a helpful reminder to us all of this important practice to better the outcomes for our patients. We will cover the evidence behind the inception of ERAS and its history, and then these latter two, the challenges to implementing ERAS, which remain to this day. Traditionally, and by that I mean really prior to the 1990s, there was a cautious approach in patients undergoing colorectal resection. We were slow to allow them to eat post-operatively, long periods of IV fluids, cautious to let them eat until they'd open their bowels, slow to get them out of bed. And this all resulted in an average length of stay of about 7 to 10 days, not surprisingly. At the beginning of my career as a junior doctor in 2011, I remember going on a ward round with the surgeon on the right there in the picture. I don't know if you're familiar with the BBC production At the Edge of Life, where they filmed the sarcoma service in Birmingham. One of the sarcoma surgeons was taking us around the wards, and when he came across a patient that we were feeding, he thought prematurely, I distinctly remember him saying this: "Don't put stuff in the top end until stuff has come out the bottom end," by which he meant, why are we giving this patient a diet when they haven't opened their bowels yet? And so this tradition, even though at the beginning of my career in 2011 I was being pushed by the colorectal consultants in particular to practice ERAS, nonetheless the tradition remained. And that tradition really began to be challenged in the 1990s if we look through the literature. I've referenced two papers here, both of which are senior authored by Henry Collette, Professor of Surgery at Copenhagen University in Denmark, and many consider the second of those papers here in 2000 to be a landmark paper, where it's quite remarkable, if we look back now all those years ago, the program that he documented in a series of 60 consecutive patients undergoing colonic resections, and these were open resections, by the way. If we look at this protocol, it's very similar to the ERAS protocol to this day. Before surgery, there was a prehabilitation or a stress on preoperative drinks the day before surgery. After surgery, day 0, early mobilization at 2 hours and a drinking target of 1,000 mils, again including protein drinks in that. Perhaps we would question some of the medication used here, but there was certainly an emphasis on opioid sparing analgesia. Look at day 1, bladder catheter was to come out, and there was a mobilization target of 8 hours. Do you know how many steps your patients are walking post-operatively on day 1? And day 2, the epidural catheter was to come out, etc. So it's quite remarkable to think all those years ago in open colonic resections, this was really considered a landmark paper in ERAS. Because these were open resections, there is mention here in the paper about doing a transverse incision across one dermatome to minimize postoperative pain. But this highlights in the laparoscopic era how ERAS comes to the fore even more. I just put in here the graph that illustrates the results. There were 3 groups of patients. Groups A and B were deemed unsuitable for the early 48-hour discharge plan. There were small numbers in these groups. Group A was just 4 patients, which were presumed unsuitable for early discharge because of mobility, preoperative mobility issues already, such as wheelchair bound, etc., or perhaps some psychiatric needs. And in B, the group B was only 3 patients which were found to have locally advanced disease at resection, requiring a more extensive resection. But group C, the majority of patients here, 53 patients you can see, had a successful post-operative length of stay of just 2 to 3 days on average. Not surprisingly, there was a correlation between ERAS and early re-establishment of gut function, and we will be touching on the science of return of GI function for patients undergoing enhanced recovery. But is it safe is a question that remained, and what were the readmission rates? Could we have detected an anastomotic leak earlier if we'd not pushed for discharge within 48 hours? These were all questions that they openly declared their readmission rates. There were 9 patients in total and 2 anastomotic leaks who presented on day 7 and day 14 post-op. The question of safety can't be answered in one paper, and we're going to look at a few other subsequent papers, including randomized studies, to answer the question of safety. But before we do that, I want to move on to the hypothesis of why could it be that an early rehabilitation program can get the gut working earlier and get patients recovering fully and in a safe way. So is there a scientific basis behind ERAS? This diagram I've taken from a freely accessible open access journal referenced here, and it's illustrating the fact that if you have a well-nourished patient that's mobilized early post-operatively and given oral nutrition rather than excessive intravenous fluids, all these act to enhance the recovery of gut function and even reduce the stress response to surgery, which in turn reduces complications, increases healing rate, and of course reduces length of stay. There have been a number of studies to try and illustrate the science. I've just put 2 papers in here, one looking at preoperative nutrition and one looking at immediate postoperative nutrition and the benefits. Many studies designed to try and show reduced hospital stay, quicker return to bowel function, decrease in the loss of muscle mass postoperatively, even reduction in postoperative nausea and vomiting, etc. Studies in dogs have shown that a low serum albumin concentration is associated with long gastric emptying times, and that if you can return the albumin concentration to normal by salt and water restriction or a high protein intake, the gastric emptying times also return to normal. And this has been replicated in humans. Here is a study in the Lancet, which is only small numbers actually, but it is a randomized study including 20 patients where 10 patients post-colonic resection were randomly allocated to a salt and water restriction post-operatively, and they demonstrated by measuring gastric emptying times that there was a quicker gastric emptying in patients with fluid and salt restriction. Passage of flatus was 1 day earlier, 2.5 days earlier to pass stool, and not surprisingly 3 days shorter was the length of stay in these patients. So in summary, here are some of the concepts to consider. The cartoon here is really a psychological concept. If patients can be at home, and when it's safe to do so, they really should be at home. It's the best place for the patient to recover in their own environment with their own food, where it's quiet, and that just makes common sense. And I haven't mentioned the risk of nosocomial infection, but of course the longer patients stay in hospital, the higher the risk they are of infection. So get them home when it's safe to do so as early as possible. Not surprisingly then, if the science is behind this, numerous subsequent studies to the 2000 paper I mentioned have demonstrated benefit of ERAS. These are randomized studies referenced here, 4 references at the end of the presentation, including a meta-analysis here in 2010 of 6 randomized studies with about 450 patients. Patients were randomized to ERAS versus conventional recovery programs, showing benefit for patients. So the question is, why are we still talking about this 20 plus years later? This was a study presented at BASO, British Association of Surgical Oncology, which was just a small study I did at the beginning of my registrar training, illustrating that we're still failing to comply with ERAS protocols in quite a few units, probably in the UK, and this was one unit I looked at which didn't have the best hospital length of stay. Some aspects of the ERAS protocol were being adhered to, but the use of our ERAS booklet, which we put in the patient files, was the uptake was quite poor, less than 50%, which possibly had a bearing on the hospital length of stay. Last week, myself and Mr. Tayeb did a laparoscopic right hemicolectomy in an 87-year-old, and here is the protocol that we use at Walsall for your interest. It has it's filed in the patient's notes for all patients undergoing colonic resections, and it has aspects of the day before the surgery, and then we expect the nurses, doctors to encourage this as well, but the nurses predominantly to go through this checklist each day after surgery to remind us of what needs to be done, what needs to come out, what targets are to be met for the patient to enhance their recovery. So I'll leave you to look at those. There is, of course, this final page where sometimes we do have to remove patients, of course, from the ERAS pathway, and there's some reasons listed there: prolonged ILIS, more than 72 hours. If there's any major complication, that means we need to divert from the pathway. So this is one of the reasons we're still talking about it. It's not a great reason now. I think traditions are they do die eventually, as evidence comes through. But I remind myself and each of us about the traditional approach that I was encountered with at the beginning of my training. But perhaps a more important reason why there is non-compliance is it takes effort. ERAS really does take an effort, because it's not one physician or one doctor's role, and not one person can implement this successfully. It really is a concerted effort. I've put a picture of an orchestra here performing at a concert, and everyone needs to be involved. Everyone needs to buy in to the protocol. That's the nurse, the doctor, the patient, the relative, the physiotherapist, the nutritionalist, the colorectal nurse specialist, the anesthesiologist, the anaesthetist. It really has to be a concerted effort, and pulling all those people together to help the patient recover in an enhanced way can be one of the challenges for complying and the uptake of ERAS. So as we draw to a conclusion, I've taken this summary slide from that open access journal that I mentioned earlier, just illustrating all the different components of ERAS, and hopefully illustrating that the answer to the question, who's the conductor, there can't be one single person involved in this. There are multiple disciplines required to make ERAS work. Pre-admission is one of the key factors to educate the patient and give the information, and the right expectation to the patient is paramount. If the patient is expecting a 7 to 10 day hospital of slowly recovering, they'll think something's wrong when we say that they can go home on day 2, day 3 after a major operation. But we as surgeons in the outpatient department and nurses must sit down with the patient and family and educate and inform them what the expected post-operative course is likely to be. Surgeon and anaesthetist must work together to try and provide the most pain-free operation that spares opioids, that uses epidural as a preference to opioid in the anesthesia and the postoperative analgesia. Laparoscopic approach, of course, aids in that greatly, but also avoiding unnecessary drains, avoiding NG tubes. And then post-op hydration, we've talked about overhydrating the patient and giving too much salt. We must educate our junior doctors on day 0 post-op to not chase the low urine output, which is expected as a response to surgery, and not to overload them. Again, we've mentioned the post-operative pain control, the early nutrition, and I hope we've got the message now about early mobilization and early enteral nutrition. And then this final thing here, discharge criteria. Again, it is useful to have those tick boxes in the notes that just give the nurses and the whole team a reminder of what is the criteria for today. What are we expecting our patient to meet on a daily basis, and then finally, what is required for the patient to be at home. Some patients spend endless days in hospital without anyone questioning it. Why are they in hospital? They're not receiving anything that they cannot receive better at home. 3 things that might help with implementation. Number 1, do you have a protocol in your unit? And do you have a means of measuring whether the ERAS protocol is being adhered to? Many units use booklets or checklists like the ones I showed you that list the criteria and the targets that are to be met for the patient for an enhanced recovery. Secondly, education. I suppose that's what we're doing here today. We're reminding ourselves of the literature and the evidence and how that needs to be reiterated. And thirdly, effort. It does just take effort sometimes to get this to work. I've said there's no one person that can make it work, but an orchestra does need a conductor, doesn't it? And sometimes there does need to be a champion or someone who cracks the whip and someone who reminds everyone to enhance the recovery of the patient. Ask the question, why is the catheter still in? Why is the epidural still running? Why haven't we fed the patient? Why is the patient still in hospital? Which there may be a good reason on day 2 or 3, but the question must be asked. Here are some questions that if you can answer them, it probably means you are practicing ERAS in your unit and for your patients. And there is a trick question amongst those as well, and you've probably spotted it. When are you removing the NG tube? Well, there shouldn't have been an NG tube placed in the first place. ERAS has really reshaped the way we think about postoperative care for major resections. This picture, is it good or bad? It looks very kind of this lady to deliver the food to this patient in bed. But wouldn't this be better if the patient got out of bed and put on some normal clothes and walked to the hospital canteen or the patient dining room to have their meal on day 1 or day 2 post-op? And I'd ask the question, which of you listening today have had their breakfast, their dinner, their tea, their supper in bed? It's not normal, is it? And this is something that's been looked at in Europe, and it gets us thinking about the way we recover our patients post-operatively. So thank you for the opportunity to present and be part of the conference here in Pakistan. Here are some of the references I've referred to today. And here is my email correspondence address if anyone wants to get in touch or even perhaps request PDF or files to be sent with ERAS protocols and pathways that you can perhaps use in your patient files to help with ERAS. Thank you once again.